So based on this objective, some of the things that we would like to look at would first, doing a lower extremity functional scale, see how it is affecting things outside of just walking and standing that maybe he's not aware of, kind of clearing that fear and avoidance beliefs side of things. From a body region, we'd look at the lumbar, spine, as well as hip and knee, do a little bit of functional testing with single leg balance, deep squat, inline lunge, really see how that foot is affected by some of the proximal segments, looking at how regional interdependence may be affecting some of that lower limb movement. Starting out with kind of a walk, progressing to a jog, depending on how his symptoms respond with just walking activities. From a motion assessment, I think it's safe to move into both active and passive, and here we can kind of move into that end feel assessment as well, looking at that single plane to triplanar or multi-plane motion, be more thoughtful of kind of being using with a little bit of caution as we're kind of loading that into 3 different planes of motion. And overpressures, yes, again with caution, but more due to see what happens at end range when we load it. From a mobility assessment, looking predominantly at kind of that ankle and foot talar curl, both A and P mobility, but most importantly subtalar inversion, eversion, as oftentimes when that kind of foot hits the ground and you need to move from inversion to eversion, if there's a limitation there, the Achilles sometimes will take that load. And then soft tissue assessment, looking at the gastrocsoleus first, probably just active motion, followed by then looking at it in a closed connect chain position, as mentioned above with kind of that first MTP and the windlass mechanism, if those 2 things are normal. And then also kind of doing a palpation assessment of the ankle inverters to see if there's any relationship to any kind of flexor hallucis, longus, and pronator that may be kind of playing into this. And then if those all clear, then I would look at neurodynamics, just making sure there isn't a nerve sensitivity due to that repetitive stress with the slump test. Motor testing, I'd look at kind of single leg stance. What's the coordination of the foot? Are they more intrinsically, meaning they're using some of the intrinsic muscles of the foot, or are they more extrinsically dominant, really trying to curl their toes into the ground, which may also play into how well their stability is. Manual muscle testing slash strength testing, what does ankle plantar flexion and hip stability look like, and then also endurance, looking at repeated heel raises, and then special tests, doing an arc sign and a Royal London test. Again, the arc sign, kind of what does symptoms do as they move through kind of ankle plantar flexion and dorsiflexion. That kind of mid-range arc tends to be more tender. And then a Royal London test, when you kind of identify where it's tender, kind of palpate it, put it on load, and then does it become less tender when it's on load for palpation. So again, oftentimes Achilles tendinopathies tend to reduce symptoms when they're on an end range load position versus a mid-range sensation. So upon exam, current findings were he had a low FAB-Q as we suspected, and lower extremity functional scale noted that he had about a 56 out of 80, a little bit additional challenges with some other activities outside of just walking and running. We did complete a lumbar, hip, and knee screen, which he had full lumbar, hip, and knee motion in all planes. Nothing big jumping out on that functional movement exam. Motion and flexibility, straight plane ankle range of motion. Plantar flexion was within normal limits. Dorsiflexion, however, was 3 degrees with the knee extended and 8 degrees with the knee flexed. And so you can tell significant restrictions in kind of gastroc flexibility. Eversion was also 10 degrees compared to 18 degrees, and so a little bit more limited on the uninvolved, or a little bit more limited on the involved versus the uninvolved. Inversion was within those normal limits. Straight plane passive range of motion was similar to active range of motion, had more of a pulling sensation when we provided that extra little movement with dorsiflexion. Because of the restrictions in the single plane motion, we felt there was no further need than to look at the multi-joint flexibility and neurodynamic testing. But something to keep in mind that we'll probably clear for a later date. So just with our base kind of examination, we identified some gross restrictions in especially dorsiflexion and eversion, which again, if we think of some of our other flexibility tests that especially like the seated slump, if you're already restricted in one single plane, you're probably just going to be even further restricted when you wind up more structures. Further testing, kind of a mobility looked at, posterior glide was a little bit limited to the talocrural joint. As we had mentioned, eversion was limited, especially to that subtalar joint. Upon palpation was tender across the gastrocsoleus, mild into the posterior tibialis, kind of behind that shin. Was tender over the mid-substance of the Achilles tendon with a palpable area of swelling that moved with dorsiflexion and plantar flexion that's consistent with that positive arc sign. And then tenderness decreased in maximal dorsiflexion, which is the Royal London test. So some of those special tests we had talked about. Motor control was within normal limits for ankle dorsiflexion and eversion and inversion. Mild weakness of right hip abductors, and then also unable to perform more than 5 single leg heel raises. And here he had significant pain and discomfort when doing that. Pronation of the foot during single leg stance, so when he was doing that balance he would kind of collapse, so even with kind of that limited eversion, his kind of midfoot and forefoot would kind of collapse a little bit, where he'd try to curl his toes under to kind of keep that arch, and then able to only maintain this for about 10 seconds. So after kind of a little bit further information, is there anything you would change in terms of your hypothesis, the patient's irritability, their asterisk sign, and prognosis?